you've got your really good surgeons in that practice, and you've got your not so good, and everybody else is in the middle. But wouldn't you want to be with the best? Why does that control costs? Because you don't have to go in again. It's done right the first time. So cost always follows quality. If you focus on the quality, you will save money.
Hello, everyone, and welcome to the Healthy Savings Podcast. I'm your host, Sasha Gribov. I'm the co-founder of Milu Health, and I'm joined by Laurie MacDonald, who is the founder and agency president of MacDonald Consultants. And we're very excited to have you here, Laurie. Thank you for coming on.
My pleasure.
You know, the way that we usually do these episodes is we try to get to know folks who are doing something new, different, interesting in the healthcare and employee benefits worlds. And so, Laurie, we've gotten to know you over the course of the past 6 months or so, and have started to hear your story about what you're doing and how, and would love to share it with everyone who's listening in. So maybe if we could start with giving a quick background on how you got here, what your agency and your work is like, and how you got into this world.
Sure. Well, my agency is in St. Petersburg, Florida, although we do have strategic partners across the country and certainly in Florida. It is an interesting journey, always, when you talk to someone about how they got into health insurance and health insurance advising specifically. For me, I had been on the other side of benefits, the 401k side. I'd worked for Fidelity Investments for quite a while and nationwide. So I saw benefits from that perspective. And it wasn't until the new millennium, 2000, I ended up working for Cigna. And my role was to make sure that Cigna health plans were sold in Florida. And I worked with different advisors in the community and told them, these are the benefits of Cigna. Why wouldn't you want to sell Cigna? And it wasn't until I left Cigna and became an advisor, and so I was a little bit on the other side of the table, working in Tampa Bay, and I saw who are the competitors. Of course, as you know, the term BUCA, Blue, United, Cigna, Aetna, and there used to be a Humana, sadly no longer. So what I realized is there really is so much parity. Even though, we try to differentiate, the network is the same. There's the big, broad network. There's the mid network. There's the skinny network to get costs down, increasingly. But there's just not that much difference moving from one to the other, and they all have their rich plans, their whole spectrum down to the very basics. So interestingly, advisors are also paid pretty much the same, and the rates are the same. So one advisor cannot get any different rates, and I don't think employers really understand that. We all get the same rates. So what's our value prop? How are we differentiating ourselves? It's not real rocket science to realize that, wait a minute, the rates go up every year. We keep on trying to implement these innovative programs to bring costs down, but it never brings the cost down. And Medicare rates aren't going up. I think the Medicare has gone up 1% a year, less than that. And health insurance goes up maybe, they say trend is 12% forever for the last 25 years.
That's wild, by the way. I didn't realize it was 12%.
Well, it's lower. It's gotten a little lower. But when you look at average renewals, I mean, I've had this past year, 47% rate increase, 68%, 35%. And if this is some employers' second largest expense on their P&L that they don't know how to manage, but they should manage, that's a huge hit. Even a 6% rate increase, that's a huge hit. You start to go down that rabbit hole of why. I know I did not fully understand, and I know most employers don't really think it through and connect the dots, but these large carriers, they are under intense pressure and they have very smart people working for them, and they have a lot of resources. They have to meet their earnings estimates every quarter. And if they're off, even by $1, there is a sell-off of their stock. So we have to follow the money, and we have to understand those incentives. They have got to make money for their shareholders. And they can't make money if the premiums go down. So you can see how it's aligned. Even though there are forays, it's kind of a dichotomy. You're saying on one side, where we have all these initiatives to help control cost and help with keeping people healthy. But in this industry, you're paid when people are sick. So if people aren't going and they're not getting the most expensive procedures, you're not going to make your earnings estimate. So we just have to understand that. And it's the same with hospital systems.
What was your path for digging in? Because, it's funny, as Gotham and I started Milu, we went down a similar path where we were just like, read and learn and talk to people and read and learn and try to figure out, how does this thing actually work? Like, from a average person who feels sick, goes to the emergency room, gets slapped with a huge bill that's not itemized, by the way, and they don't understand what's on there, and then maybe 1 in 100 tries to fight it, to someone gets a drug and it's expensive, but then magically maybe they get a card in the mail and it's free, but someone's still paying for that drug, so who's paying for it? To employers who can't afford the healthcare that they want for their employees because it's a huge line item. Like, there's so many layers to the onion. Where did you start? What did you read? Where did you go?
To start to
Yeah.
unravel this. I am a member of our trade association, which has been recently renamed NABIT. It's a mouthful. National Association of Brokers and Insurance Professionals. So that is a wonderful resource for advisors. And I started connecting with advisors across the country, which brought me to Health Rosetta, which continues to evolve and grow and has amazing resources, and to stay connected and on trend, because it's constantly evolving, and it's almost the Wild West with all the different players and vendors coming into the space to try to control healthcare. And then I got familiar with NextGen, and that's another group of national advisors who share best practices and their experience, their real life experiences. So being involved with those 3 organizations was huge for me.
That's awesome. And who are the types of employers that you typically work with? Like, what do you look for in an employer to think like, what I'm doing can actually be a good fit for them, versus, like, we're at a different place and a different time, and this isn't the right place for the kind of plan that I can help with?
Well, good question. And I think I made a mistake initially being overexcited about some of the ways that are available to control cost. And I did learn through trial and error that employers are really more worried about disrupting their members, their employees, than about cost. Of course, cost is a huge issue, but they have budgeted for it. They haven't budgeted for as high as some of these renewals are. But there is more reluctance for member disruption than for addressing the cost. So I work with all the traditional health plans. I work with Blue, United, Cigna, Aetna, and they are absolutely the best fit for some employers. For those employers that want to be a little more aggressive, and they do actually want to start to get the data, you can't fix what you're not measuring. And if you don't have the data, you can't fix it. If you don't have any more importantly, actionable data, then you don't know what's driving your cost. If you ask most employers, what is driving your cost, they're not going to be able to answer you. If you ask them, what is your average per employer per year spend, they do not know. So we have done a disservice to employers by isolating them from the actual workings behind the scenes of a health plan. And we've done the same thing with employees. We have taught employees not to be incented or care what the cost of something is. And they've gotten kind of spoiled. You can think of it as, here's your ID card, go put $1 million on it. No questions asked. And employees are not really taught to get a second opinion. If a doctor says to do something, they just do it, even though the statistics are kind of astounding. I think the most recent I heard was that 63% of spinal surgeries are not needed. They don't even need to be done. And 70% of cancer treatments, which is where big dollars are the wrong treatment. So we've divorced employees and members from really digging in and asking questions and finding out where is the best care. They don't know quality metrics. That data is not available to them unless they partner with and are in a plan that's actually feeding them and encouraging them to use that data and incenting them.
It's really wild to see the dichotomy between, like, we'll go and talk to people about Milu, everyday people, friends, family members, uncle, cousin, random person down the street, not really, but, and half the people will say, oh my God, I have a $400 bill sitting on my desk right now that I don't know what to do with. Some of them will say, and I can't pay it right now. And then the other half will say, but I don't care. Like, I just want a great doctor. I don't pay for anything. Like, it's all covered. I've got insurance. And it's a weird thing because I think a lot of those people will still go get a big bill, just nothing bad has happened. In a few of the earlier episodes, both Carl and Barry had given examples of like medicine in the 80s or in the 70s or prior generations where someone would go in and like a doctor's visit would cost you $80 and you'd expect to pay it and you pay it because, insurance isn't supposed to pay for the $80 thing. Insurance doesn't pay for changing your car tires. Insurance pays when you're in a car accident. And so we've got the system where everything's convoluted. Half the time you pay a ton, you don't know it. And half the time you don't pay anything. And so you don't think about it. And the costs go up for everyone as a result. Right. I don't know how to solve it. Or, I have some ideas, but it's a hard problem to solve.
I think the common denominator in what you were just saying is that there's a lack of transparency. It's hidden, and it would not have been allowed to exist if it wasn't hidden. If we really saw all the numbers and understood it, everybody would be screaming. So it's purposely hidden. And why is it hidden? Because everybody's marking it up every step of the way through the whole supply chain of healthcare. A doctors only make, I think it's 27 cents of every dollar is what a clinician receives. So if you just went to that clinician outside the system, you would pay $27 on a $100 bill. But if you go through health insurance, you're paying $100.
That's the other part of all this that bothers me. Like, I have a bunch of friends who are doctors who are some of the smartest friends I have, the hardest working, and relatives. And there's more administrative burden than ever before. There's more burnout than ever before. It costs way more to become a doctor than it ever did, by the way, just like any kind of college education. Separately, I didn't know this until getting into the space, but there's a ban on physician-owned hospitals. Like, in the past, physicians used to own the big hospitals and not anymore. And that makes it a lot harder because administrators are running hospitals instead of doctors in many cases. And physicians get paid less and less every year by Medicare. I think one of the things that gets me excited about some of the types of health plans that you and other folks like you design is they're not meant to limit the physician fee schedule. Like, the doctors getting paid what they need to get paid to do their work are not the problem in the U.S. healthcare system. And I don't think that's widely known. But like, there are ways to solve the problem, but actually give doctors more time back. And we have to find ways to do that.
You're right. It's not the doctors. And even if you just look at a typical bundled surgery, the real fat is in the facility charge. It's not going to the surgeon. And then even less goes, there'll be some that will go to the assistant. So, where is all the money going? I think pharmacy has a lot of hidden layers in it. That's the highest margins right now. And the facilities have a lot. But then, of course, facilities are not set up to run super efficiently. So it would be a huge change. And a lot of facilities, hospitals in particular, and it gets really complicated. But there's a whole spectrum of hospitals, right? There's like the small rural hospital, and then there's the big city part of a big hospital system. But a lot of them are having a hard time balancing their P&L too. So their balance sheet and their P&L has a lot of crazy expenses on it, and it's very difficult to ever dig in. Luckily, Marilyn Bartlett, an accountant who actually brought the state of Montana from the red by 12 million into the black. She's a forensic accountant who can figure that out. But most people, and she had a lot of roadblocks, but she actually was able to follow the numbers and follow the money and solve it. So people are doing that across the country bit by bit.
That's really cool. I've seen her speak before, and it's an amazing story. It actually worked, and not at a small scale, but across a whole state.
And yet, even though we have these amazing examples, there's huge pushback. But Patient Rights Advocate, that is a nonprofit that has the ear of certain legislators. And I know that Health Rosetta will be going to Washington this year. They're picking an election year in September and getting the message out. Even on the Super Bowl coming up here, there is going to be an ad run by Patient Rights Advocate, which actually mentions hospitals and insurance carriers. Not specific ones, but just in general, hospitals and insurance carriers. And the whole tact that they're taking is, okay, Congress has mandated that they have to put estimates down, that we have to be able to find what is the estimated cost for a procedure. And this commercial is basically saying that's bullshit. And that's the kind of it's built around, estimates are bullshit, because you can't plan something based on an estimate. Why can't we it's not rocket science. All the numbers are there. This is the code. This is what it's negotiated. What's the price? Where else in America do you just say, here's my credit card and let me know later? I tried to help a lady find out what her labs were going to cost. We knew the codes. The doctor told us exactly what the labs were. Every lab, there were like 10 labs. And we knew who the carrier was. We knew it was going to be Quest, big national lab. We've got
by the way, big win there by doing it at a Quest versus at the hospital lab. You probably saved 50% just by doing that.
Good point. Right. Always better. Anything at the hospital is going to be more expensive. As a matter of fact, in Florida, you can't even anymore. There's a lobbying effort which made it illegal to get an infusion, to bring your infusion and get it sourced at a lower cost and bring it into the hospital to be administered. You have to get the hospital delivered medicine, which is 10 times more expensive.
I had no idea that was written into law. So you can't do home infusions, or to do it you have to
if it's done at the hospital, you can't bring the infused drug in. You have to buy it from them, and it's called white bagging. And
got it.
It just increases the cost.
Wild. So you were telling the story of trying to find lab costs.
Yeah. So I tried so hard to just find out ahead of time. We know the negotiated rate for each of those labs. We know where they're being done. What will be the cost? But could not get it. Absolutely could not get it. Could not get it from the carrier. Could not get it from Quest. She just had to put her credit card down and hope It wasn't going to be too much.
It's funny. We've dug into the price transparency data, and it is a really big deal that it's now out there. But what you can do with it is still very, very limited. Like for the life of me, I can't find a good facility fee for a specific hospital for a colonoscopy with a carrier. And you can get a lot of directional stuff. Like there's incredible things you could do with it. I do think it'll bring costs down, although others have argued it could bring costs up. Whatever. It's a right first step, and it'll get better. But it's not there yet. What are some wins? Like it's really easy for us to sit here and say all this stuff is broken and it all sucks, because a lot of it does. But out of your clients where you're seeing some successes, either directly with like some employees or broadly, what are some of the things that get you really excited?
Cost is a big one. I've got a construction firm, probably about 80 enrolled, and they had a flat renewal for 3 years, which is pretty unheard of. So they did not have to pay more, and they have a hugely rich plan. They don't pay anything for labs. If they go in the hospital for 2 weeks, it's a $500 copay. If they have a surgery, it's $250. Most folks in this area on a traditional style plan, a surgery in a hospital stay, you're going to be about $6,000 to $9,000. You're at your out of pocket, and that's
Out of pocket, not billed to the plan. Billed to the plan's 10-20x that, I'm assuming.
Correct. Just the member experience. Anything expensive that's not in the copay realm is going to go to the out of pocket, and you're going to hit that out of pocket every time if you're in the hospital or you have a surgery.
Like how did you get flat increases for 3 years in a row with this group, especially in construction? Like that's not an easy industry.
Right. We have put in some navigation is the biggest, I think, biggest reason for reducing cost. Most surgeries and hospital care is planned. Of course, if it's an emergency, you just go to the nearest emergency room. And we don't have time to negotiate anything up front. So you just go. Now, we did put something in place to try to help mitigate emergency room visits. We have a $750 copay for emergency room. But if you will make a phone call, even if they just say, oh my gosh, you definitely need to be going to the emergency room, we'll call ahead. We'll make sure they meet you there, that they're expecting you, that they'll get you through the emergency room faster. But if you make that phone call, it costs you $0. That's your incentive to remember that if you need an emergency room visit, make the phone call. If you don't, then it's just $750, as would be in a typical plan. If you end up making the call and you talk to an emergency room physician, they may keep you out of the hospital. So often, emergency room visits don't really need to be emergency room, and they can be diverted to more effective and more cost-effective care, clinically and cost win. So maybe you rolled your ankle, and they can get you, really what you need to do is you need to get into an orthopedic, and that's not going to happen at an emergency room visit. They're just going to tell you, yeah, you should go, but you need to visit an orthopedic. They're going to get you, maybe you need some pain meds, and they're going to help you get that appointment made. So we're also, by just having them make that phone call, we're keeping emergency room visits down. It's the most expensive way to get a lot of care, where it could be easily and more effectively and safer for the employee done at another setting. The other big thing is anything planned. We are going to negotiate the best possible fee with the highest quality surgeon. The biggest indicator is for quality is volume. If you're doing it a lot, then you've got your own team typically. Probably have an ambulatory surgical center, which is always a win because you've got your whole team. When you do it in a hospital, you don't have your team. You have who's working at the hospital, and it's different all the time. That increases, it's less efficient Plus, there's higher infection rates. So anytime you can move it from a hospital to an ambulatory surgical center, that's already a win. But if we can make sure that you've got the best surgeon for what you need, you could go to an orthopedic practice and it's well rated, but maybe the one surgeon that is really good at hands is not the one that you're going to see. You want to be going to the one that specializes in hands. There is, and I didn't know this before I really got into this, but there is just like anything, it's a bell curve. You've got your really good surgeons in that practice, and you've got your not so good, and everybody else is in the middle. But wouldn't you want to be with the best? Why does that control costs? Because you don't have to go in again. It's done right the first time. So cost always follows quality. If you focus on the quality, you will save money.
That's awesome. One of the things that we've done over the course of the past year is map out where is the quality data, because you hear these anecdotes of people calling in and getting guidance, and it's amazing, but your average American has no idea. They go to whomever they were referred to. Sometimes that referral is amazing. Sometimes it's, your mother's uncle's cousin went to someone and that's the name that you got, and you go. And there's just better ways of doing it. So one of the things that we're passionate about is similarly, how do we get that information to the patient at the time that it matters and get them real data on, here are a few doctors near you who have done a lot of that procedure or have the best outcomes or who patients love. And I agree with you. I think we can really move the needle if patients have access to that information ahead of time.
Right. I think the trickiest thing I've found in getting them the data is the trust factor, because a lot of times they perceive that you're trying to send me to the least expensive. And in our heads, we think least expensive is lowest quality, which is not true. And actually, surprisingly, when you're really good at doing something, your cost comes down. And so it's not the case, but there is that trust factor. And typically maybe it's your primary care doctor is going to refer you to a certain specialist. If they're in a hospital system, it's going to be someone in that hospital system. You may ask around, and you're going to get anecdotal info from the bedside manner that your brother-in-law experienced, something like that. Neither one of those are clinical quality points of reference. So we can get them the clinical data, but it has to be in a manner where they actually trust the data. And that's been a challenge.
Have you found any solutions to it?
I think it needs to be explained a bit. You can't just say, okay, here's two names. It has to be a little more comprehensive. This is why we're recommending these two. And then they start to have a warmer, fuzzier feeling about it.
It's funny, in the early days of Milu, I think I'm going to remember this for a decade. We were showing the product to some folks, and in that iteration, we always have some sense of pricing, but we had like 3 doctors and some quality metric, and then we had price, and there was like highest price, average price, and maybe a reasonably priced. And the person's like, "I'm going to the highest price one."
Absolutely.
Like, that's the good one. Like, I know this trick. That's the good one. We're like, no, like, there's no correlation. Like, that doctor doesn't set the price. That doctor was, let's say they were top of their undergrad class. They went to a great med school. They work at this great hospital, or they work in a private practice. They have nothing to do with the price. The price is set by someone in some room negotiating with some insurance companies, and that's the price. And like, that's not the doctor, and no one knows that or sees that. So it's an uphill battle.
Yes, it's another one of the many ways in which typical economic laws don't work. Typically, you get what you pay for. You would think you pay more, you get better, but that's not the case.
Makes total sense. Well, one thing I'd love to ask you about is, as you think about where all of this goes, like where healthcare in this country is headed, where healthcare for employers you work with in Tampa is headed. What are you most excited about, and what are you most afraid of? Like if we're having this conversation again in 5 years, what do you hope will have happened?
Well, I think we're seeing small employers just have to give up on health insurance. That the number of small employers that can afford to offer health insurance has really dropped. And there is a safety net of the individual market. But if you're over 50, that doesn't exist because you will be penalized if you don't offer it. So for those employers, I think I keep on thinking we're at a tipping point. I think they're getting frustrated enough that they're starting to say, "What else is there?" They're so afraid of disruption, and it's really the employers that have employees that are maybe a lower, maybe the $18 an hour folks, and maybe high turnover. They're the earlier adapters, I think, because they charge by piece, or it's the way the accounting works. They are kind of being driven into this by price. I don't see the adaptation of trying different things in the more professional, like an attorney group would not be a great fit because they don't want the appetite for disruption is about zero. And if we can just the disruption can be managed. It kind of falls into two categories: eligibility and claims. So if we help make sure that the doctors that people are going to understand the plan ahead of time, and that we've maybe smoothed the way by reaching out ahead of time and making sure they understand that these employees are eligible for this insurance, that helps. Another thing that helps is when they have the claim, just making sure that we have good partners to reach out and smooth the way. It's really it comes down to health advocacy, and really a lot of employers are reluctant to do this unless they're bigger and they have the staff. Is we ideally have a health advocate within the company that is really kind of digging into it, rolling up their sleeves, and helping employees navigate it, because everybody wants to have the Cigna plan at half the cost. That's what all employers want. I don't want to make any changes. I want the plan to work just like this is, but I don't want to pay so much. But we do have to make some changes if we want to do it differently. And that's really about change management. And can we have someone within the organization that is trusted, that employees can go to help them manage the change? But we've got to get the employees engaged.
It's funny, the employees engaged piece is the thing. We've talked about a lot of different things over the past 30 minutes. The one place that we've chosen to focus our day in, day out is how do we get people engaged, and how do we use technology and humans to drive behavior with information, starting with people getting information and being engaged. So I agree. I think there's a lot that we can do if we can crack that nut. Well, thank you, Lauri. This has been awesome. It's been great speaking with you, and I'm excited to continue the conversation and to learn more and more about groups you work with in Tampa and how their plans go.
Well, thank you, Sasha. I appreciate it.
Thanks for listening to Healthy Savings by Milu Health. If you would like more information about any of the topics you have heard today, we would love for you to get in contact with us. Find us on the web at miluhealth.com.